Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I am your pharmacist, Paul White. We're very glad you joined us. Before we begin, I'd like to thank our sponsor, Aultman Health System. Today, Brad and I are broadcasting from our administrative offices, and our special guests are Dr. Stephen Eric Olyejar, Medical Director of Aultman Cancer Center and Radiation Oncology, and Dr. Raza Khan of Aultman Hematology and Oncology. Good morning, gentlemen, and welcome to the show.
Good morning, indeed.
Morning. Thanks for having us.
We'd like to remind our listeners that today's program is available on our podcast. Just look for Health Matters with the Medicine Center Pharmacy, and please subscribe to our program. Lung cancer is one of the most common causes of cancer death in the United States for both men and women. Just this year, 234,000 patients have received diagnoses of lung cancer. November is Lung Cancer Awareness Month, so today we will be discussing the therapies with our Aultman colleagues.
So, good morning, Dr. Olyejar. Please tell us about your background and career with Aultman.
Great. Yeah, good morning. So my name's Eric Olyejar. I'm a board-certified radiation oncologist. I grew up in Colorado and went to medical school at the University of Colorado. I did my residency at the Medical University of South Carolina in Charleston, and spent the majority of my career, almost 20 years, in Phoenix area, the greater Phoenix area. Came to Aultman about 2.5 years ago, and took over the radiation department, which I've been the medical director of, and I took the job as the medical director of the Cancer Center just over a year ago now.
So what is radiation oncology?
Sure. So radiation oncology is the discipline of medicine where we treat cancer with either radioactive materials, which we can put inside tumors or inside of patients, or with external radiation, which is the most common. Usually that's done with an X-ray machine.
Dr. Khan, please tell us about your background and your career with Aultman.
Oh, hi, good morning. I had my medical degree from University of Health Sciences in Pakistan. Then I came for training here, and I trained in internal medicine in University of North Dakota, and then trained in hematology and oncology in University of Michigan in Ann Arbor. And the luck brought me from Ann Arbor to Canton, to the Buckeye land, from Wolverine land. So I came in 2002. So I've been here since then for about 22 years. So I've seen all the growth in the cancer program here. I happen to be the chair of our cancer committee for American College of Surgeons Commission on Cancer for past more than 10 years. I'm also the president and director of Aultman Cancer Center of Excellence. And of course, I see my patients every day, Monday through Friday. And I'm glad that you give us a chance to share our views and some important information about this lung cancer, which is the worst in terms of mortality. So if we look at the data, the lung cancer death surpasses the next 4 cancers death put all together. So it's a big problem, and for the most part, it's a preventable disease. To have focus on lung cancer and public awareness is the most needed thing that we can do for reducing the cancer death.
Doctor, can you talk about what Aultman Hematology and Oncology is?
So when we train in discipline of oncology, most of us are trained in hematology as well. So there is a common area of malignancies in which if you would train in hematology only, you would be treating cancers such as leukemias, lymphomas, multiple myeloma. So if you're trained in medical oncology, the same thing happens. You are trained in all this, what we call solid tumors, like lung cancer is one, colon cancer, breast cancer, prostate cancer. But you also get trained to treat those, what we label under hematologic malignancies, which hematologists by training do as well. What the hematologists do in addition is they also treat the benign hematology problems such as anemia, low platelet count, somebody has clotting disorders, congenital factor deficiency, like aware of hemophilias, Christmas disease. So all those are labeled under benign hematology. So when we train it together, instead of 2 years training after internal medicine in hematology and another 2 years in oncology, which may take 4 years, due to this overlap, we train in 3 years. So that allows us to see the benign hematology, hematologic malignancies, and solid tumors. So in Aultman hematology and oncology, we have 3 experts in this field working right now. We have some locum help, which actually makes it about 5, and 2 more of our colleagues joining early next year to make it back to our original number of 5 hematologists and oncologists available to treat the cancers and the blood problems. So that's the focus of Aultman hematology oncology. So we don't treat with the radiation like Dr. Olyejar does. We don't operate the patients like the surgical oncologist will do. Our focus is mostly on systemic treatment, which means either the intravenous medicines or medicines taken by mouth to treat the cancers.
Gee whiz. So, what are the causes of lung cancer? I know there's a million of them, but I've heard people say, "Oh, I smoked all my life and I haven't gotten lung cancer."
Yeah. So smoking is the number one cause of lung cancer, and recent data would support that about 80 to 90% of all lung cancer deaths in the United States are from smokers. Those who smoke are 15 to 30 times more likely to develop a lung cancer than those that don't smoke. And the risk is directly proportional to the number of cigarettes you smoke per day and the number of years that you smoke. It's something a term that we use in cancer as pack years of smoking. So one pack of cigarettes smoked per day for a year is a pack year. So the more pack years that a patient has, the more likely they are to develop a cancer. Secondhand smoke is probably the second highest risk of developing a lung cancer. Non-smoking, thought to be the second most cause is radon, which I think we're going to talk about in a bit. Also, some air pollutions. Those that have been identified would be diesel fumes, engine exhaust, benzenes in particular. And then there's some industrial exposures that we're certainly aware of, like arsenic, chromium, nickel, tar, and then asbestos is also one that was used a lot to insulate back in the 50s. Radiation exposure is also known to cause lung cancer. So patients who get radiation to the chest at a young age for diseases like Hodgkin's disease or breast cancer, they are at slightly increased risk of lung cancer. And then HIV infection is another one that we know increases risk.
Both of my parents died of lung cancer or mouth cancer. My father started at age 14 in a steel mill. And you can imagine in the 30s and way back what the steel mill back then was like as far as pollution goes. But he died at a very young age, so very different. But he was a metallurgist, spent his life in a steel mill, and of course smoked. So, but I happen to be an expert at picking up cigarette butts because I have 5 stores. Okay, and I just cannot get over the amount of smoking that is still going on, and it's like it just continues to increase as opposed to decrease. Do you have any stats on that?
Yeah, we saw we were presented some data at our cancer symposium this past weekend that compared to the 60s, smoking is less than half of what it was in the 60s. But a lot of the smoking, especially in younger people, has been replaced with vaping. And we definitely have some data that vaping does increase the risk of lung cancer as well. So it's definitely not a safe replacement for smoking cigarettes.
So vaping, nicotine in the vape, or what is in it that's toxic?
I don't know any data on that in particular, but It may just be at the actual mechanism of it as well, too. Do you know any more on that, Dr. Khan?
So we're talking about the vaping.
Vaping, yeah.
Yeah.
So it all depends on what is in that capsule that you put in that vaping device. If it is nicotine only for a recovering smoker, it's not a bad idea. It allows them to slowly come off the more ominous, those polyhydrocarbons and dozens of carcinogens which are present in tobacco. If there's any contamination or purposefully additive to nicotine, then that can be harmful. And there's a whole list of what those suppliers have subjected the users to. There have been acute toxic deaths to chronic addictive dependence on those vaping products if they keep using it. So it all depends on the intention of who's making it. Is it accidentally mixing something or purposely mixing something other than nicotine to make their product more sellable? For most part, what is being sold as nicotine is nicotine. So that's not as bad a problem. Nicotine in itself is not a great thing to have, but it does allow the smokers to gradually come off their habit of smoking tobacco.
And on that point, the data clearly would point out that patients who do quit smoking, their risk of lung cancer falls every year that they don't smoke after they quit.
Okay, gentlemen, it's time for our first break. You're listening to Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters with the Medicine Center Pharmacy. Are you ready for vaccine season? Stop in or schedule your flu, pneumonia, COVID, or shingles vaccine online at medicineshoprx.com. Okay, what about radon gas? I know there's a couple of areas around here in the Canton area that used to be coal mines, and some residences and homes have been built in those areas, and that the radon is a real issue. What about radon? How's it associated with lung cancer?
So yeah, radon is found largely in the soils. So as it decays, it emits a gas that is breathed in, and it causes damage to the lungs. And it's thought to be the second leading cause of lung cancer in the United States after tobacco smoke, primary and secondhand smokers. And it is clear that people exposed to radon that smoke, their risk is much higher than non-smokers that are exposed to radon. You know, radon, it's something that you can test for in your home very easily. They actually have kits on Amazon that you can use to see if you have radon or not, and then it can be quantified to see what the levels are. There's a lot of things that can be done to reduce radon gases in the home, like sealing the crawl space and ventilating the crawl space can actually get levels down to very low levels. There's recommended levels by the EPA that really help reduce cancer. But yeah, you're right. This is one of the areas that has some of the most highest levels of radon in the soil anywhere in our country.
There were coal mines in North Canton for a company up there, and the allotment where many of these homes are, and I have a friend who lives in that, and he said, my gosh, he said the radon was serious until we, installed cleaning devices. Okay. Why should someone consider screening for lung cancer?
Sure. So as Dr. Khan mentioned earlier, lung cancer is the number one killer of all the cancers, and it surpasses most of the really common cancers that everyone thinks about with regards to cancer death. And the mortality rate, the death rate from cancer, is directly related to the stage at which it's diagnosed. Cancers are diagnosed or staged based on how extensive or how early we find them. So a stage 1 cancer means it's confined just to the lung, and the tumor is relatively small. Cure rates for a stage 1 lung cancer can be anywhere from 80 to mid 90% range, depending on the size of the tumor. So again, the earlier we find it, the better. Whereas a stage 3 lung cancer, it's usually less than half of patients are alive at 5 years. And stage 4, virtually no patients will survive 5 years. So the earlier we find the cancer, the better success rates are at curing it. The screening for lung cancer has evolved a lot over the last 60 years, where they used to just everybody would get a chest x-ray at their doctor's office, which unfortunately isn't a very sensitive test for finding lung cancer at an early stage, to where we are now, which is something called a low-dose CT screening, where patients get a very fast CAT scan that takes just a couple minutes. And it's a very high resolution, so we can find cancers at very small sizes, less than a pea even. So when we find those, we actually have a much better chance of curing patients.
So what about talking about radon? Okay, you're from Colorado, is that correct?
Yes.
And there are many, many silver mines out there, in the past century and stuff like that.
Mm-hmm.
What about the radon experience out there? Is it big time or?
It's regional, a lot like Ohio. There are pockets that have a lot of radon, and then there are pockets that have none at all.
Okay. Interesting. I was thinking, oh, it's so beautiful out there now. How can a radon be out there? It's so beautiful,
Mm-hmm. It's a naturally occurring element, so yeah.
Interesting. Sorry, Brad, go ahead.
So who should, we talked about CT screening. Is that the primary means of screening for cancer? And who's eligible, or who should think about getting screened?
Yeah, so the guidelines for screening for lung cancer, we talked about that pack year smoking. So patients who have smoked at least 20 pack years are who we'd recommend for screening. So that's one pack of cigarettes a day for 20 years, or 2 packs a day for 10 years. And if patients are not currently smoking but have a 20-pack year smoking history, and they quit with less than 15 years, they should get screened. And the recommended guidelines are to start screening at age 50 for those patients, and keep screening those patients until we think they don't have a reasonable lifespan. So if they become very unhealthy from other medical problems, they usually stop doing screening studies like we do with a lot of other cancers. But it is covered by insurance. It's very quick in and out. You don't have to get.
That's where I was going. Yeah.
Yeah.
Okay.
Mm-hmm. Yeah, if I may add something to it, like the rate of screening still needs attention. So when the data was looked at just about 5 to 10 years ago, only 3% of population was getting screened, those who can potentially benefit. Where are we right now? It's at the best in teens still, whether it's 15, 16, or 13, somewhere there, which means over 80% of those who can benefit from screening are still not getting it. Either it's not being offered to them or they're ignoring it, one or the other. So what we need to do is direct to the beneficiaries knowledge, reach to them to say you need screening. If you have a friend and he's smoking, ask them, have you smoked for those sort of 20-pack years, which means they smoked 1 pack per day and they smoked for 20 years. What if their pack had been smoking 2 packs per day for 10 years? That would be the same thing, 20-pack year history, smoking too much. And their age is 50 to 80. And you realize that's my friend. I have this bit of knowledge, pass on to them. Say, I'm concerned about you. Would you please mind calling your family doctor and get it screened? And the second set of this education is to stress the family doctors. Those are the first line of defense against this, to order it, offer it to the patients, have a discussion that you need it. So like stage 1's mortality is just about maybe 20% or 15%, versus when we have even a stage 2, the mortality is 60 or 70%, from 10-20% to 60-70%. So it's a huge difference when it's caught like a 1 or 2 centimeter small spot on a screening CT, versus you already have a shoulder pain or you're coughing up blood. Things are gone to a stage where it's not curable. It's like a day and night difference. So anybody you love, the knowledge that they should be screened. Don't hesitate, ask them to do so. So the best screening we have is over 60% for breast cancer and cervical cancer, pap smears and mammogram. So even in our best possible screening, we're still into between 60 to 70%. Lung cancer lags behind all the screening. So it's still at the best in its teens. So a lot more can be done to prevent that 160 to 70,000 patients dying in US, to maybe bring it down to less than 100,000, to less than 50,000 if we stick to the screening.
And I'd add to his point too, pre-screening, the incidence of finding, so the chances of finding someone at a stage 1, hovered somewhere in the 20% range. And I saw a presentation from a researcher in Copenhagen, and they have national health. They had 90% of the patients screened, and their stage 1 incidence 5 years after that was almost 90%. So they shifted it from 20% stage 1 to 90% by instituting a national screening policy that was widely adopted. So it really makes an enormous difference.
Interesting. So, have you seen anyone diagnosed with lung cancer from screening?
I saw one this week. I would imagine that we see one to two patients at our tumor board every month who are screened. How about you, Dr. Khan?
Yeah, it's common. At least 1 to 2 is probably a fair number. And as we are concerned about it, that the rate of screening is very low. The rate goes up, it may jump up to maybe you're seeing 10 or 20 patients who are screened and diagnosed. So you would have literally thousands of people screened and actually narrowed in to those who need biopsied and actually biopsied and confirming cancer. The number keeps dropping. But the outcome is just so drastically different for those who are screened and caught and treated. So you can fail at, didn't do screening, screened, but did not do the biopsy, did not do the biopsy, did the biopsy, but did not do the next step of treatment. So you can fail at multiple levels. A lot of them are short of resources, or they just lack the conviction. They're afraid they have to quit smoking. So you keep finding, say, why did you take 6 months between the screening CT to come to the next step that should have been taken? So you'll find variety of barriers there, why it didn't happen. So to really impact mortality, we have to fight on each and every stage to start the screening. And then, so we tried doing it, like we have a lung nodule clinic here. Then we have the lung cancer navigators in Aultman cancer program. So their role is to find out those, if they have been screened, to try to channel them, to streamline, to get it to them to the next stage where they need biopsy, to sort of hold their hand, call them, say, did you do it? So we tried doing beyond that step, beyond the national guidelines, to see what more we can do for our patients' health. So those navigators are following them. And we have systematically tried following this lung nodule clinic to focus on this patient, to take on them to go to the next step after the screening has been started. So first step, the family doctors order a screening test. Once a nodule has been found, and then that's our colleagues who are following those patients to make sure they go to the next stage, which is biopsy.
Okay. Hey, doctor,
And another,
go ahead.
The Aultman is doing currently is they're applying artificial intelligence to the CT scans that are being done for other reasons, not screening scans, but perhaps someone's in the hospital with chest pain and they do a CT scan to rule out other things. AI is applied to the read to see if they have any nodules that might need to go into this lung nodule clinic. And they've referred a number of patients through that already.
Okay, doctors, bottom of the hour, time for the news. Thanks for joining us this morning on Health Matters with the Medicine Center Pharmacy. Yes, you are listening to Health Matters with the Medicine Center Pharmacy. I'm your host and pharmacist, Paul White. This morning we are talking with Dr. Stephen Eric O'Leary and Dr. Raza Khan from Aultman. Where are we at?
Well, I
Okay.
think it's time we talked about radiation treatments.
Yes, it is. Right. What is radiation treatment options for lung cancer?
Sure. So the options for patients again is really going to depend on the stage of the cancer, and we use radiation for different stages of cancers, and the technologies that we use are quite different. So probably the most common treatment that we use for lung cancer is in conjunction with chemotherapy for cancer that spread to the middle of the chest. We usually call that a stage 3 disease. And that's done with an X-ray machine. Typically, these are daily treatments. Patients lie on a table and a machine will rotate around them and shoot X-rays targeted at the cancer that we can see in the lung and the lymph nodes. These treatments usually take in the neighborhood of 3 or 4 minutes. In and out the door of the treatment facility in about 10 minutes. And those are 5 days a week and usually come for about 6.5 weeks. During that course, they'll usually get chemotherapy either weekly or every few weeks, depending on the diagnosis and what type of cancer.
So go ahead. I'm sorry.
Yeah, so that's for stage 3 disease. There's another treatment that we use quite often for patients with stage 1 disease called SBRT. SBRT is an acronym that stands for stereotactic body radiation therapy. It's a fancy way of saying we give radiation very focally just to the tumor, and we give extraordinarily high doses of radiation each treatment. We use the term a lot, stereoablative radiotherapy, or SABR. So the dose that we give to the area that we treat is high enough that it kills everything in that sphere. And typically these patients are treated every other day for 3 or 4 doses. The control rate for this radiation, depending on tumor size, is in the upwards of 90+% for these stage 1 cancers. So it really rivals the cure rate for surgery. So currently we use that treatment for patients with early stage cancer who are not eligible to have a lung surgery. So a lot of these patients will have COPD or emphysema, so very poor lung function, and they're not eligible to have part of their lung removed without significantly compromising their ability to breathe and function. So this is a great option for those patients where we can offer a very high rate of cure without having to expose them to surgery and risk.
What about the tissue around the cancer? Do we burn that tissue very badly, or is it much more focused these days than it used to be?
Yeah, so it's extraordinarily focused. There's a lot of things that we have to take into account with a lung tumor when we're doing these treatments that, especially if you imagine on the lower part of the lung near the diaphragm moves up and down with respiration. So, what we don't want to do is treat a huge long area of the tumor where the tumor is moving in and out, because we are going to treat a ton of lung tissue. So we have a technology that we use called respiratory gating. So what that does is it only turns on the treatment while the tumor's in a specified portion of the respiratory cycle. So we're able to take those margins and shrink those down very tightly around the tumor. We do have to put some margin around it to account for microscopic tumor spread. So patients will lose some lung capacity from these radiation treatments, but it's a very small amount when you compare that to, even a wedge resection for a lung cancer. I liken it to if the surgeon could go in with a melon ball scooper and just scoop the tumor out and get it completely out and remove it. That's really what we're doing with radiation treatments.
Wow. You're up, Brad.
All right. So you talked about gating. What about the differences between chemotherapy and radiation?
Sure. I'll speak on the radiation piece. So the radiation, you can think of it as it's a local treatment. Think of it as replacing surgery. Its job is to kill the cancer that we know about and can see. And it's aimed and targeted directly at those tumors and tumor nodules and lymph nodes that have cancer in it. I'll let Dr. Khan explain more about the chemotherapy part, but when we use chemotherapy with radiation, one of its primary benefits is it makes the cancer cells more sensitive to the radiation.
So, Dr. Khan, let's talk about chemotherapy and what it is with lung cancer.
Yeah, so we're going to talk about those systemic treatments, as I previously mentioned. So those are the ones that we give intravenously or in the pill form, which means it goes to the stomach or intestine and gets absorbed, still gets into the blood and goes through the entire system. So we call them systemic treatments. So radiation, as just Dr. Olyejar mentioned, that's a focused way, like surgery, to deliver radiation to the area of disease. The systemic treatments, they tend to go through your entire body and they have consequences. Some to our benefit and some to our disadvantage. Just before I touch on all these systemic treatments, just something to share with our listeners. So we're going through a period of enormous knowledge, so if you want to call it a knowledge explosion, you can call it. We, in our entire career, used to have our most seminal, the most important research publications, mostly published in New England Journal of Medicine, which is very esteemed journal to look at what has changed. And then the Journal of Clinical Oncology had the next most important information. Similarly, Lancet, that publishes from Britain, or British Journal of Medicine. So those were the key ways to find out what is happening. When we used to have those 5 or 6 publications in a year in New England Journal of Medicine, we would have to read it and say, these are practice-changing articles. We got to read it. We got to know it. It used to be very easy to know it and 5 or 6 times read it very carefully and see what happened. Just in comparison, the journal is published weekly. So it's every week you look at it, there are 1 or 2 new medicines which are published, which has a practice-changing impact. So 5 or 6 years, 52 weeks time, 1 to 2 new things being introduced to you, which are going to be beneficial for some patients. So it's just, there's no way to compare how things are changing and what we have to keep up with. So it's beneficial for us to, even within medical oncology, have some of us focus on a certain type of cancer, then another colleague do another type of cancer, just to be able to keep up with it. Like I slept with certain knowledge about lung cancer, and I woke up and things have changed. If I did not read it on that day, I'm already behind. We have to continuously look at those journals. Digital media is still, in this day and age. I'm flying next Saturday, actually Friday, to attend 7 in the morning till 6 in the evening updates on lung cancer. Even somebody like myself, who chairs the lung cancer tumor board, which is twice a month, I can't keep up with it with one disease. So that's the pace of discovery these days. The human genome project was completed. The normal genes were defined, went to the abnormal genes, and now we have the price to pay, find out what is happening. So good thing. It's all good, but it's really challenging to stay in touch with it. So we have this. The first tool that came with the systemic therapy was chemotherapy. So now we're going to talk about relative differences between the chemotherapy and the next type of systemic treatment. We got into what we call targeted therapies. So chemotherapies, traditionally, most of them, almost more than 90%, will be given intravenously and goes through the entire system or the entire body. So they were traditionally chemicals discovered by the chemist and found to be doing something, and then found to discover they had biologic activity. Then went to the animal testing, and then came the tumor models where you could create a certain type of cancer in an animal, test those chemicals and say, are they active against this type of cancer? Then it went from the animals to human testing to find out that these chemicals, what we call the chemotherapy, are truly chemical in nature. They always had some target. Some were targeting the DNA of the tumor, the other were targeting maybe mitochondria. So it is not that the chemotherapy does not have a target, but the targets are sort of more wider. So some of those processes that the chemotherapy target to kill the cancer cells are also shared by the normal cells. So the amount of side effects that we are used to seeing with chemotherapy can be more broad-based, because the same targets that the cancer cells use, the normal cells use too. So we give these chemotherapy in very early stage, trying to cure the cancer. Those are called adjunctive or additional treatments. After the surgery, sometimes with the radiation, to try to cure it. A lot of other chemotherapy or the systemic treatments are given in a stage of disease which is not curable. Then the goal is to keep patients' quality of life the same or near normal as they are used to, and help them live longer. In other words, improve their survival. So the first tool that we came to use in all those settings was chemotherapy. And then we have additional ways now that we try to influence these cancer-causing cells, starting with the chemotherapy and evolving into other newer treatments that we offer the patients now.
I need to interrupt you guys, gentlemen. This is a good conversation. It is time for our final break. You are listening to Health Matters with the Medicine Center Pharmacy. We'll be back shortly. Welcome back to Health Matters with the Medicine Center Pharmacy. This morning we're talking with Dr. Khan and Dr. Olyejar. I am your pharmacist, Paul White. Thank you for joining us. Let's get back to the last segment of the show.
Well, doctors, I wondered if you could talk about the impact of treatment on survival. We already talked about how important screening is, and how it's pretty underutilized in the community, it sounds like, and we need to all tell our friends and family, if they're smokers, to think about getting screened. I'm sure that in itself can be a challenge for people who smoke. Sometimes it's a challenge to get the patients to go see their doctor once a year. But I think that you've shared that important message, but let's talk about the impact of treatment on survival.
Yeah, just to continue our discussion about the targets. So we had these targets, the DNA was targeted, the spindles, which lead to cell divisions, were targeted, but so the normal cells were doing the same thing. So we started seeing those side effects. Then we say, well, can we do something better than that? So as a direct consequence of these projects like Human Genome Project, I remember Dr. Francis Collins, who was head of NIH for 3 different presidents. He advised regarding health matters and just left that job about maybe 2 years ago. He was the chief of genetic medicine in Ann Arbor. He was picked up from there, brought to National Institute of Health, and this Human Genome Project was given under his supervision. Him and his colleagues, they completed the normal gene set, what the human genes should be. There was multiple countries involved in accomplishing that. Then in comparison, the same and other groups of scientists, they were trying to figure out, is the tumor genes somewhat similar to it, somewhat different than the normal genes? It resulted in finding out that a huge amount of data that we now know how the tumor genes are different than the normal genes. It has allowed us to find out medicines which can be targeted. So we're calling them targeted therapy, to have the exact pinpoint defect in the tumor targeted, kill those cancer cells, avoiding side effects of medicines to other cells. To give you the most intriguing example is the condition chronic myeloid leukemia, or CML. The best treatment that we had for most of those patients, let's say we going 20 years back, was injections interferon, which had quite a bit of side effects, like you have the worst case of flu. And the median survival, which means half of the patients are living, half of the patients are past, they're dead, was about 3 years. The small subset of patients could have allogeneic stem cell transplant, which means they could get donors stem cell, high dose of chemotherapy given with a 50% chance of dying from the side effects of treatment. The remaining 50%, for some, the chemotherapy was affected. Maybe about 5, 10, 20% of those would have long-term survivorship. Came this first drug, imatinib, which was targeting BCR-ABL. So that was the abnormal gene resulting in transcription of the gene, a protein product. So this particular drug was targeting BCR-ABL. The survival, the median survival, which was 3 years, the first group of patients that went on those clinical trials, about 70% of them, over 20 years from where we started the trials, are still living without any evidence of progression. So just imagine 20 or 25 years living versus 3 years of median survival for patients who had chronic myeloid leukemia, just by discovering a single fact, what's the defect. So defect were BCR-able. So this is how it has impacted survival. Other diseases, maybe not as drastically, but a significant impact. Like multiple myeloma used to have median survival of 2 to 3 years. Now we're talking about a median survival of 10 years. So those patients, if I see them, if I see you a decade later, it's quite possible. Like a single month 3 years ago in December had 4 practice-changing publications about multiple myeloma in a single weekly publication. So that was dubbed as December to Remember. So this is how the impact of knowledge is resulting in improved survival. We're certainly seeing it. And then there are some other stubborn cancers like pancreatic cancer or stomach cancer, where we're not seeing such an impact now. So it's a bit of a mixed bag. Then came the next best thing that happened was the introduction of immunotherapy. So that's a different class of drug which is impacting patients' survival and outcomes.
Well, doctors, we're getting close on time, and I want to make sure that you both get an opportunity to share what you're passionate about and your final thoughts that you want patients and listeners to take away from our conversation today. So, Dr. Olyejar, you want to go first?
Sure. So, yeah, I think if you take away anything from this talk, number one, do recognize that smoking causes lung cancer and is a killer. Quitting smoking will reduce your risk of developing lung cancer. So we do have a lot of resources available for patients who want to quit smoking. See your primary care doctor, see your pharmacist. And number two, screening saves lives. So if you or someone you know is a smoker, encourage them to talk to their primary doctor about getting a screening test.
Dr. Khan?
Yeah, I would want our patients and population in general to make them believe in their health system. So don't get swayed by my friend's mother-in-law's cousin's best buddy had a treatment given in Mexico, which did blah, blah, blah. Come with an open mind. Your family doctor means well, your cancer doctor, your radiation doctor, your surgical oncologist, they all mean well. They may not be able to get you a new life. They may not be able to give you 20 years of life, but whatever is available in their means, for most part, they're decent people. They're on your side. They want to fight with you. So don't believe in these alternative conspiracy theories. Believe in your health system. It is the most expensive health system in the world, but allow me to say that we have the highest cancer survivorship compared to any other country in the world. So yes, we use our resources, we spend the money, we spend hours of research, hours of clinical expertise, we fight on your behalf, but we are with you. So trust in your system. For most part, who you are seeing are decent people who are on your side. Fight the cancer, standing with them.
Wow. Well, Dr. Olyejar and Dr. Khan, thank you very much for being on our program today. It was very interesting and very knowledgeable. If you suspect you have a medical issue, please contact your healthcare provider. Thanks to Aultman Health System and our listeners for joining us on Health Matters with the Medicine Center Pharmacy. Have a healthy week, and we'll see you right here again next Friday on News Talk 1480 WHBC. Have a good day, gentlemen. Thank you.
Thank you so much.
Thanks for having us.
Thank you very much.
Right. Bye-bye.
Take care.
Bye-bye.
Bye-bye.